Welcome to our presentation on knee injuries. So the objective for this lecture is to provide overview of common knee injuries, to understand the mechanism of injury, so how the injuries can happen, our different signs and symptoms, and how we should provide care for our injured patient. So first area we're going to talk about are sprains. Again, sprains are injuries to ligaments, and strains with the T are injuries to tendons and muscles. So the ACL is a very common injury in athletics, and our typical mechanism of injury is plant and twist, tibia externally rotated with lower leg abducted. So on the picture there, the picture on the right side is showing that plant and twist motion. And most ACL injuries are caused by what's called non-contact. So somebody just plants and twists, and the ACL is torn because it can't handle all that external force while the leg is abducted. Another another MOI is hyperextension from a force to the anterior knee or the front of the knee while the foot is planted, causing the tibia to be forced posteriorly. So somebody's leg is planted, so they get a direct hit coming straight forward on their tibia, causing the tibia to go backwards, and that tears the ACL. We're going to talk about grades of sprains soon, but just a general thought here is that the signs and symptoms become more severe with each grade. Again, we have 3 grades of sprains here too, just like we did in the ankle. Typically, the athlete will hear or feel a pop. There's going to be rapid swelling. That knee is just going to get super fat and swollen really fast. And we'll have some kind of positive stability test in the lab. I'll go over all the various stability tests for the knee. And when they're walking or weight bearing, it feels like the knee's going to slip forward. It feels very unstable as they're walking. So then we have the posterior cruciate ligament sprain, PCL. This doesn't happen too often. I mean, in the time that I've been an athletic trainer, I haven't seen that many PCL sprains. So we land directly on the knee with the knee flexed. So in this picture, that would be the bottom right picture. That's what's going on there. So that forces the tibia anteriorly, or moving it forward, since the PCL stops posterior or backwards motion of the tibia. Our signs and symptoms here, again, the athlete feels the pop at the back of the knee versus the in general. Okay, then the swelling is going to be more on the back or the posterior of the knee, and we have positive stability tests. Then our medial collateral sprain. So the picture shows a really good is a good picture of how this happens. So we got a blow to the lateral side or the outside of the knee. So foot's planted, get a hit from the outside of the knee, it's a valgus force, or moving the lower leg out, or we have extreme external rotation versus, I should have done the LCL at the same time, but the grade 1, again, this is going to be for all our sprains. Grade 1 is minor pain, swelling, and point tenderness, full active range of motion, and passive range of motion. They got some stiffness, and they don't have a positive stability test. Grade 2 is now it's beginning the swelling, point tenderness, and pain is going to be pretty increased. We have reduced active range of motion and passive range of motion. We have reduced muscle weakness, and we have a positive stability test here. So again, a grade 1 sprain for any kind of ligament sprain. Grade 1 is about 1% to about 20% torn ligament. Grade 2 is 20 to 75 to 80% of the ligaments torn. And grade 3, it's completely ripped in half. So we have pretty severe, moderate to severe pain, swelling, and point tenderness, loss of range of motion. They can't move it. They have a lot of pain. They don't have any strength. And we definitely get a positive stability test here. Now the LCL, again, we have this picture here where we get a blow from the medial side or the inside of the knee, like the picture is showing, and it stretches the outside of the knee, or we have extreme internal rotation. Signs and symptoms are the same as the MCL sprain. The treatment for all of the sprains is price. So we protective crutches. If, as with the ankle sprain, if we have a grade 2 or greater where they can't weight bear, they can't walk on the road, they need to be placed on crutches, get it immobilized, which we talked about in the splinting area. We need to get it x-rayed just to make sure there's not a fracture. That's what the R/O stands for. Rule out fracture. FX means fracture. So that's just my philosophy. I think that's just a wise thing to do when we're taking care of people. It's not a 911, but they definitely need to go see their orthopedic doctor or the general doctor as quick as possible. Unhappy or terrible triad. This is a rupture, so a complete tear, a grade 3 sprain of the MCL, ACL, and the medial meniscus. This typically happens when we have a direct blow with external rotation and lower leg abducted with foot planted. So it's the same range of motion, same mechanism injury as the ACL tear, but now the foot is planted and we have a direct blow. ACL is typically non-contact. This is a contact injury and the foot is planted. So this is a pretty bad injury where everything's torn up. This is a good 9 to 12 months of rehab. So anytime we have a grade 3, that's going to be surgery. Typically, there's some debate on the MCL and ACL and LCL on surgery for those, but that's another class. Meniscal tear, so we tear, it's also known as a cartilage tear in the knee. So the medial meniscus happens to get torn more often because its lateral is pretty loose on the tibia, so it can slide around a little bit more. And it's the MCL, the medial meniscal is attached to the MCL. So typically when we injure our MCL, we got to see if the medial meniscus is injured. Typically it is. Here we have excessive internal or external rotation. The signs and symptoms here are pretty specific. So with the ACL tear, we have, and most of the sprains in the knee, we have immediate swelling. Here with the meniscus, we have delayed swelling, 24 to 48 hours after the injury happens. The knee may give out or lock up. They may have a clicking or popping sensation. When they squat, they have a lot of pain, or when they're going up and down stairs. And let me say something else about, whoops, went the wrong one. Hit the wrong way. Sorry. The delayed swelling is what's called at the joint line. So if you bend your knee 90 degrees and feel your knee, right, you should be able to feel the joint line. I wish we were in lab and I can show you how to do that. So again, it's not a lot of swelling compared to a sprain. So treatment here is really got to get them to the doctor. They're going to need to have an MRI or a CT scan, determine if the meniscus is torn. And typically this is a surgery that you need to have because you can't really repair a meniscus because it just does not have very good blood flow to it. It's a pretty simple surgery as surgeries go, and the recovery from it is pretty simple because they just basically go in there and cut out the area that's been cut or torn. because that's what it is. It gets torn, and then you basically from there you're working on pain and swelling, and then they can get back usually in a couple weeks. Okay, bursitis, also known as water on the knee. Just as a reminder, a bursa is a fluid-filled sac. I think it is a jelly donut. And the bursas are between skin and bone, between a tendon and a bone, or between a ligament and a bone. So they provide cushion for the bones, the ligaments, the tendons, and the muscles. And there's a ton of them in our knee. The primary ones that get injured in our knee are the suprapatella, so that's on top of the patella, prepatella, which is below the patella, superficial and deep infrapatella, so that's going to be one above the patella, one below the patella, and the pes anserine is on our lateral side of our knee. So how this gets injured is a direct blow. They land on their knee typically. This is also known as a carpenter's injury. So the carpenters would be on their knees all the time and their knees would just swell up. So we got tons of swelling, like a balloon on their knee. It's pretty obvious when you see it. It's warm to the touch because of the swelling, and again, there's loss of range of motion because there's so much swelling in that knee. So here we have compression, anti-inflammatories, medication, and we typically the best way to do this is send them to a physician, to the doctor, and they drain the knee. They stick a needle in the area where the thing is swollen. They'll typically might do a CT scan or something like that so they can make sure where it's at, but they typically don't. They stick the needle in there and they suck out the swelling, and everybody feels better after that. You put a Band-Aid on it, and they're actually pretty good the next day. Chondromalacia patella. Everybody probably has this condition. This is, you have a deterioration of the cartilage at the back of your patella. So on that picture, you can see the femur, and then on the back of your patella, what happens is we can have abnormal patella tracking. And if you look at your femur, there's a groove in your femur between the condyles, and that patella could be out of the right track, because the back of the patella has like a V to it, and it should slide back and forth between the femur condyles every time you flex and extend. Sometimes that gets off track for whatever reason. Maybe you have a weak vastus medialis or vastus lateralis, or you can have wider hips, or you can have some kind of anatomical flaw like we talked in the lower body and the foot. If you have high arches, low arches, all those things come up to your knee and cause problems too. So our signs and symptoms for this is a grinding sensation. So if you put your hand on your knee and start flex and extend, especially in the cold weather, and you feel some grinding going on there, that means you have chondromalacia patella. You can have a dull, achy pain around the patella, pain with jumping, squatting, running hills, or climbing stairs. As it gets cold, your knee hurts more. That's me. I have this in both my knees pretty bad. Every time it's cold here in Fresno, my knees start hurting. Got the old man disease of bad knees. I can tell it's going to start raining. And so our treatment here is, we really can't fix this. I mean, they can go in there and scrape the back of your patella. If it's so bad that you can't walk anymore, you probably just need a knee replacement. Usually heating it up with moist heat packs, ultrasound before practice, because when the knee is worn, it feels better. So we'd use a knee sleeve with a hole typically around it. If we can see that the patella is tracking incorrectly, we can fix that tracking problem. And again, the knee sleeve keeps that knee warm, and so that's one of the reasons why we want to use it. We may have to strengthen the quad, especially the VMO, which stands for the vastus medialis obliquus, or the for whatever reason, the vastus medialis obliquus is the weaker of the muscles for whatever reason. Next one is patellar tendonitis, also known as jumper's knee. The patellar tendon connects the quad to the tibia. So here we have the inflammation of the patellar tendon, and this is a chronic injury, so we have excessive jumping, kicking, and running, which is sports. Here the tendon is very tender. The tendon is thicker than the contralateral side or the other side, just like we talked about in the Achilles tendonitis. It's hot to the touch, warm to the touch, and a pain when we're using stairs or squatting. This is a tough injury to get rid of. We really have to limit the activity that's causing the pain. We typically will heat and ultrasound before practice or games and ice afterwards. We do use these straps. There's a ton of different straps and different like KT taping and stuff like that we can use for this. Another one is the cross-frictional massage, like I talked about with the Achilles tendonitis. It's a brutal injury to overcome. Any of the itises, they're pretty hard to overcome. That next injury is patellar rupture. This is when the patella actually comes out of the insertion point in the tibia. So we have a massive muscle contraction here of the quads. It's usually torn at the tibial tubercle, and that's again where the the patella attaches to our tibia. The patella rolls up to the thigh, like in the middle of the thigh. We have that deformity because of that, and severe pain and swelling. And what do you think should be done with this? It might be a test question. Who knows? Iliotibial band friction syndrome. I forgot to talk about the iliotibial band in anatomy, so we'll talk about it now. Iliotibial band is part of our hip. Goes from the top of the hip all the way down to our knee. It's a band of connective tissue. It's part of the tensor fasciae latae muscle. And then it's a big, thick, wide band all the way down the side of your leg, on our lateral side of your leg, and it attaches to the knee, as you can see in the picture. So we have a friction between the IT band and a lateral femoral, or femur, and also at the fibula. So anything that anything that requires repeated knee flexions and extensions, such as cycling, cross country, and rowing, may lead to this. We have pain at the lateral knee that radiates to the joint line. So this picture does a good job showing some of this. We got pain with resisted range of motion as knee passes 30 degrees flexion. This is where the IT band shifts over the condyle. It's a no-brainer when you see somebody has this. So here, it's another itis, another chronic injury. It takes forever to heal. May need to do a cortisone shot with this. Depends on the doctor's philosophy. Definitely anti-inflammatory medicines and ice. Heat before, ice after, those type of things. Schlatters disease. I always pick this one because I like to say that. This happens with kids, adolescents, preteens, teenagers, because they're playing sports or jumping a lot. The patellar tendon pulls away from its insertion on the tibia. So we have pain and point tenderness at the tibial tuberosity, which is again where the patellar tendon attaches on the tibia. And that is a growth plate, and that's where we grow when we're teenagers. We grow there. This can be a problem. That's one of the problems with this injury is with Schlatters. It's right on the growth plate, and that can be a problem with the person growing. So we have pain there at the tibial tuberosity with range of motion. We can have that deformity at the tibial tuberosity, and we got to treat this pretty conservatively because we can rupture the patellar tendon from the tibial tuberosity. I mean, this is something that if you think somebody has this, you set them to a podiatrist, orthopedic specialist, to make sure they don't have this. I mean, I've never seen this. I've seen people have had it since I primarily worked with college kids. So some of my college athletes had it when they were growing up, and you can see the big old bump at the tibial tuberosity. So review, we talked about acute injuries, all the knee sprains. We had 4 different knee sprains. We talked about a meniscal tears and patellofemoral rupture. Those are all acute injuries. Then we talked about our chronic injuries, bursitis, chondromalacia patella, PF tendonitis, IT band friction syndrome, Osgood-Schlatters disease. So not too many injuries, but quite a few injuries here with the knee